Hello student. Now we are going to discuss the regulation of coronary circulation and cerebral circulation. Pulmonary circulation will be discussed in respiratory physiology. So start with coronary circulation. So all of you know that the coronary circulation or the supply to the muscles of the heart is done by two major arteries, that is the left coronary artery and right coronary artery. Through these two arteries, the total amount of blood that is flowing in the muscles of the heart is equal to 250 ml per minute. So this is the amount of coronary circulation, or the muscles of the heart is getting 250 ml of blood in 1 minute, right? So if you express this amount into percentage of your total cardiac output, so if your cardiac output is around 5 liter, so it will be approximately 5% of your total cardiac output. This has already been asked in MCQ, so please remember this information. Now the approximate weight of the heart is 300 gram. So if you express this 250 ml in terms of 100 gram of tissue, that is another unit we express the blood flow. So that will be approximately 84 ml. So 80 to 84 ml per 100 gram of tissue per minute. So if I ask you that how much blood flow the muscles of the heart is getting per 100 gram of tissue, then your answer will be 84 ml per 100 gram of tissue in 1 minute, right? So this two information is required to remember for MCQ purpose. Now after that, you remember that whenever a person is doing exercise, right, what is going to happen? So exercise will increase the cardiac output, right? So you know that maximum amount of cardiac output that can be increased during exercise is 4 to 7 times, right? So if your cardiac output is 5 liter, if you are doing severe exercise, this cardiac output can be increased up to 35 liter per minute also. So cardiac output will be increased up to 4 to 7 times depending on the severity of the exercise. Whenever this cardiac output is increased, this coronary blood flow, okay, this coronary blood flow will also increase, right? Coronary blood flow will also increase, and that increment is approximately 3 to 4 times increment is possible, right? So these two information is additionally given in guidance, so try to remember these two information. Now our main discussion is the regulation of this coronary circulation. So to discuss that, first of all, you look at this diagram. So this is taken from Genome. All of you know that both of these coronary arteries, that is the left coronary artery and right coronary artery, they are originating from the root of the aorta, right? Root of the aorta. That means I can easily understand that the pressure inside this coronary artery will be equal to the aortic pressure, and that is a very, very crucial point that you have to remember. So pressure of coronary arteries is equal to aortic pressure, right? So the pressure inside the coronary arteries is aortic pressure. So when this coronary artery is supplying the muscles of the heart, how this supply is done? Okay, to understand this, you look at this diagram. So suppose I have taken a portion of the myocardium tissue. So this is a portion of the heart muscles, right? The epicardial coronary arteries, or the major coronary arteries, that is the left coronary artery, right coronary artery and their branches, they will remain mainly at the level of epicardial region. So suppose this is the epicardial region and this is the endocardial region and this is the chamber of the ventricle. So this is ventricular chamber, okay, this is the ventricular chamber. So the blood is present inside this ventricular chamber, right? So I told you that the major coronary arteries, they are located at the level of this epicardial region. So here they are located. Now multiple branches will originate from these epicardial coronary arteries, and these branches will penetrate, okay, will penetrate through these muscles of the heart, okay, and it will reach towards this endocardial region. These are known as the intramuscular arteries. So this is the epicardial arteries giving branches, that is the intramuscular arteries, and these intramuscular arteries, they will mix up with one another and they will form a plexus this plexus is located at the level of this endocardium. That's why this plexus is known as endocardial arterial plexus. So this is known as endocardial arterial plexus, right? Okay. And there will be origin of multiple branches from here that is actually going to supply your muscles of the heart, right? So what you are getting, the main blood vessels present at the level of epicardium, from there intramuscular branches are originating, and from this these intramuscular branches, they are mixing up with one another and forming the endocardial plexus, which is going to supply the muscles of the heart. Only you have to remember that this innermost 0.1 millimeter muscles, 0.1 millimeter thickness of the myocardium muscles, they get their nutrition, they get their supply directly from the blood which is present in the ventricular chamber by the way of diffusion. Getting my point? So all the muscles of the heart is getting their energy supply, oxygen supply from this epicardial, then intramuscular, and then this intraarterial plexus. But only the innermost, that is the endocardium portion, 0.1 millimeter portion, they are getting their supply directly from the blood which is present in the ventricular cavity by the process of simple diffusion, right? So just now we have understood that this major artery which are located at the level of epicardial region, the pressure here is equal to the aortic pressure, right? So this pressure will try to cause perfusion of the muscles of the heart, and who is going to oppose the pressure which is present at the level of ventricle. This will try to squeeze the muscle and it will try to oppose the perfusion of the muscles of the heart. Getting my point? So this aortic pressure or this coronary artery pressure is trying to perfuse the muscles of this heart, and this ventricular pressure is trying to squeeze the muscle, so it is trying to oppose the perfusion of the muscles of the heart. That's why we say that coronary perfusion pressure, right, is equal to okay, aortic pressure minus ventricular chamber pressure. Getting my point? So this will determine whether the muscles of the heart will be perfused by blood or not. This is equal to the coronary perfusion pressure. Now let's try to discuss that if this is the formula of coronary perfusion pressure, then the ventricular muscle will be perfused in diastole of the heart or systole of the heart. Getting my point? Because we all know that perfusion to the coronary vessels or the muscles of the heart is a phasic in nature. So let's try to understand that. So first I am writing aortic pressure. So normal aortic pressure is nothing but our standard blood pressure. So if we take the blood pressure of the person is normal, then we know that systolic pressure at the level of aorta is 120 millimeter of mercury, and the diastolic pressure at the level of aorta is 80 millimeter of mercury. So diastolic pressure is around 80 millimeter of mercury. Now we will try to understand that what will happen to this ventricular pressure during this systolic condition and during this diastolic condition. And this ventricular pressure we have to consider separately for right ventricle, separately for left ventricle. So for left ventricle, right, for the left ventricle during systole, what is the ventricular cavity pressure? Could you recall the cardiac cycle chapter? Could you recall the Wiggert's diagram? We have seen that ventricular pressure and aortic pressure, they rises proportionally during the ejection phase of cardiac cycle, but ventricular pressure a little bit higher than that of the aortic pressure, otherwise the ejection is not going to happen in the first time, right? So that's why during the systole, the ventricular pressure can rise up to 121 millimeter of mercury. That means little higher than that of the aortic pressure. So now if I calculate this coronary perfusion pressure, so what will happen? Aortic pressure, that is 120, and ventricular pressure is 121. That means the difference is minus 1. If the difference is minus 1, do you think the perfusion of the muscles of the heart is going to happen? Answer is no. And that's why we know that during this systole, the left ventricular muscles is not going to get blood. So that's why I'm writing here no blood flow. No blood flow will occur during this time. Right? Similarly, if you try to calculate during diastole, so what is the left ventricular pressure during diastole? We know that left ventricular pressure, not only the left ventricle, even the right ventricular pressure decreases to a very minimum level at the end of isovolemic relaxation phase. I told you repeatedly, and that pressure is minimum, and that pressure is near equal to 0. So 0 millimeter of mercury is the pressure of the left ventricle at the end of isovolemic relaxation. So if now I calculate the perfusion pressure here, what I am going to get? Now I am going to get the perfusion pressure of 80 minus 0, so plus 80 millimeter of mercury. So plus means now the perfusion is going to happen. So I am writing here, so obviously the blood flow is going to happen in the left ventricular muscle. So now you look at, so in case of left ventricle, what you are finding out that in case of left ventricle during systole, no blood flow is happening in the muscles of the heart, but during diastole, obviously the blood flow is happening. This is for which ventricle? Left ventricle. Now you look at for the right ventricle, it may be different, so we will look at that. So for right ventricle, again the same thing I have to do. For the right ventricle, okay, during systole, what is the maximum pressure? Okay, could you recall that? Yes, so right ventricle is ejecting blood to the level of pulmonary artery, and pulmonary artery maximum pressure is 24-25 millimeter of mercury. So right ventricular pressure, chamber pressure, even during systole is only reaching up to 25 millimeter of mercury. So now if I calculate the coronary perfusion pressure, so that will be 120, that is the aortic pressure, minus 25, that means it is plus 95 millimeter of mercury. So do you think the blood flow is going to happen? Answer is yes. So blood flow will continue. The blood flow will continue in the right ventricular muscle even during the systole. Now calculate what will happen for diastole. Obviously the diastolic pressure in the right ventricle will be 0 millimeter of mercury. Okay, diastolic pressure will also be 0. So 0 means again the difference will be plus 80 millimeter of mercury, means again I can understand that blood flow will obviously occur even during the diastole. So now you compare this thing, that for the right ventricle, the blood flow to the muscles of the ventricle is occurring during systole also, during diastole also. But if you look at this perfusion pressure, then during systole, perfusion pressure is more than that of the diastole. Then what is your conclusion? Your conclusion is that for the right ventricle, the blood flow to the muscles of the heart occurs during systole also, even during diastole also, but the blood flow is little bit more during systole than during the diastole. Getting my point? But for the left ventricle, the blood flow only occur during diastole phase of the cardiac cycle. Getting my point? So generally we say that the blood flow to the muscles of the heart occur during diastole only, but that is not absolutely true. That is true for only the left ventricle. That is not true for the right ventricle. Okay, right ventricle is getting blood for systole also as well as diastole also, and little bit more during systole. Now if I ask you, systole means which phase of systole, sir? Could you specify? So if I ask you, right ventricular muscle will get maximum blood flow during which phase of systole? Your answer will be during ejection phase of systole. Very important for future MCQ. During ejection phase of systole, the right ventricular muscle will get its maximum blood flow. For the left ventricular muscles, it is getting blood flow during diastole. So which phase of diastole? During the early stage of diastole, particularly the isovolemic relaxation phase of diastole. So please remember this information which is very crucial, right? So now your concept is that coronary supply, coronary blood flow, okay, is phagic in nature. Why it is phagic in nature? This is similar to the other muscle because of the intramuscular arteries are there that will be compressed by ventricular pressure. But that phagic blood flow is continuous in case of right ventricle, although there will be fluctuation, but for the left ventricle the blood flow will only occur during diastole. This discussion is beautifully described in Genong. So this is the graphical representation I have taken from Genong. You look at everything will be clear after this discussion, okay? And the perfusion pressure that I have calculated, that is also given in Genong, right? So now you look at, so first of all you look at the above curve. So first above curve, this one. So this is aortic pressure curve. This curve we have already discussed, right? So this is the percussion wave, okay? Then this is the tidal wave, okay? Then this is the notch, and then this is the dicrotic wave, okay? And then this is the diastolic. So this is the aortic pressure we have already discussed. Now look at these two lines, this broken line, this broken line. What is this? This means this is the phase of systole, this is the phase of systole, and the remaining portion is the phase of diastole. So looking at the aortic pressure, we can determine that which phase is systole and which phase is diastole, and that is given here. Now you look at the blood flow to the left coronary artery. What you are finding out? This left coronary artery blood flow, it is picking up to a very high level during which phase of cardiac cycle? During the diastole. I told you already that for the left coronary artery, blood flow occurs only during diastole, okay? In systole, there may be a very little bit blood flow, but not all phases of systole, okay? That's why you are getting a curve like this. So this indicates that the maximum blood flow is occurring during isovolemic relaxation phase. Now you look at the right artery, right coronary artery blood flow, means right ventricular muscle. So you look at the maximum blood flow is occurring in which phase? That is in the phase of systole. Phase of systole means which phase of systole we are talking of? We are talking of the ejection phase of systole. During diastole, there is a little decrease in blood flow, but it continues. Getting my point? So that's why we have to remember this concept that coronary blood flow is occurring in which phase for right ventricle and left ventricle. They will give you the image-based question, and in image-based question they will only give you the aortic pressure curve, and here they will put different point like suppose A, suppose B, suppose C, suppose D, and they will ask you the left ventricle gets its maximum blood flow during which point. So in these cases I have to mark C point. But if I ask you right ventricle muscles get its maximum blood flow in which point, their own answer will be point number B. Getting my point? So this way the coronary blood flow concept is important. Now the main part in physiology is that how this coronary blood flow is regulated, right? So regulation of coronary blood flow, regulation of coronary blood flow, okay? Who is going to regulate it? Okay, so regulation of the coronary blood flow, you know, it is mainly done by local metabolites. Local metabolites. Look at why local metabolites concept is important here. So suppose this artery, coronary artery, is supplying blood to the muscles of the heart, and this is the venous side, okay? This is the venous side, and in between this is the muscles of the heart. You know that how much oxygen is extracted by the muscles of the heart from this arterial blood? Getting my point? So the arterial blood is reaching here, it will have an oxygen content, and then it is going for the venous blood. In between, some oxygen will be extracted by the muscles of the heart. Remember, the muscles of the heart extract generally 70 to 80% of oxygen from the arterial blood. Huge, this is huge. Means remaining oxygen in this capillary blood at the level of these muscles is very less. Means if by any way muscle is demanding more oxygen, then this blood will not be able to give extra oxygen to the heart muscles. Getting my point? That is the limitation, that it is extracting huge because its demand is huge, and that's why it is extracting huge amount of oxygen, 70 to 80, and because of which it is said that artery, venous oxygen differences, this is known as artery minus venous, oxygen differences is maximum in case of myocardium, maximum in case of muscles of the heart, and that is on an average 10 ml, or the range is 11 to 13 ml per 100 ml of blood or per deciliter of blood. Getting my point? So if you look at the normal artery venous difference or any tissues of your body overall, suppose if I ask you what is the normal value of this artery venous difference, are only 5. Means if you measure the oxygen content of this arterial blood, suppose this is 20, and oxygen content of the venous blood, that is 15. So difference is only 5. That is for the normal tissues in the body. But in case of myocardium, it is difference is 10 or more than 10, means the remaining oxygen here in the venous blood will be 10 ml per 100 ml of blood per deciliter of blood. That means if the myocardium is demanding more oxygen, the only way to give extra oxygen to the muscles of the heart is by increasing the blood flow, only by increasing the blood flow. Okay, means fresh blood you have to enter inside the myocardium, otherwise you are not going to get extra oxygen to the muscles of the heart. That's why this muscles of the heart or myocardium has an indigenous mechanism, and that is metabolite mediated vasodilatation. What is that? When the muscle will demand extra oxygen, when the muscle is doing some more work, like for exercise. So whenever the muscles is doing more exercise, there will be accumulation of metabolites at the level of this muscle. This metabolites is going to causes dilation of this artery, coronary arteries, and because of the dilation, more fresh blood will enter. So that's why the main regulation of this coronary circulation is done by metabolites. Okay, metabolites. So whenever heart muscle is working more metabolites will be produced, and metabolite is going to causes vasodilatation, right? Coronary artery dilatation. What is the metabolite? The main metabolite you have to remember here is the adenosine, right? So adenosine. So whenever the muscle is working more and more, okay, so look at this here, look at this muscle coronary, myocardium is working more and more. So what will happen? The adenosine triphosphate will be broken down. More and more adenosine triphosphate will be used. So it will be converted into adenosine diphosphate. That will be further converted into adenosine monophosphate. And some of this adenosine monophosphate will be converted into adenosine. And this adenosine is going to causes dilatation of the coronary artery. So that's why it is clearly written in every book that adenosine is a potent coronary vasodilator. Whenever the muscles is working more of adenosine will be produced. Not only adenosine, you have to remember H plus ion is also responsible for this. Okay, the lactic acid is also responsible for this. The potassium is also responsible for this, and certain prostaglandins are also responsible for this, right? Not only that, carbon dioxide is also there. So these are the factors that you have to remember, metabolites mediated coronary vasodilatation, right? Second thing of this coronary regulation you have to remember is a term which is known as autoregulation. Autoregulation, right? This is also important. Autoregulation means, obviously auto means self, so self-regulation. If I ask you what do you mean by self-regulation, what is regulated? Blood pressure of the coronary artery, blood flow in the coronary artery, blood velocity of the coronary artery. What is self-regulated? Your answer is blood flow to the coronary artery is self-regulated, regulated by heart muscle itself, okay, irrespective of your blood pressure. So what is that? If I draw a curve, you will understand this in a better way. So this is the curve where x-axis is the blood pressure, okay, and y-axis is the flow, coronary blood flow, right? So x-axis is the blood pressure, systemic blood pressure, and y-axis is the coronary blood flow. In this, I'm drawing a curve like this where you are getting a plateau, okay. So this plateau is starting from, okay, 60 to 200 millimeter of mercury blood pressure, 60 to 200 millimeter of mercury blood pressure. What this means? This means although your blood pressure, okay, although your systemic blood pressure is rising from 60 millimeter of mercury towards 200 millimeter of mercury. But if I look at the coronary blood flow is remaining constant. That means there is a plateau in the coronary blood flow, and this is known as auto-regulatory zone of coronary blood flow. So what is happening? Although your systemic blood pressure is changing, but your coronary blood flow is maintained constant. So this constant maintenance of blood flow in an organ, irrespective of your blood pressure, is known as auto-regulation. The vital organ in our body, like for cerebral circulation, it will also have an auto-regulation. Like for muscles of the heart, that is the coronary that we are discussing, it will also have an auto-regulation. The renal system, when you will discuss, you will also find out the renal system also has a strong auto-regulatory system, right? So it is constant maintenance of blood flow irrespective of your blood pressure, right? So auto-regulatory range for muscles of the heart is 60 to 200 millimeter of mercury. You may get a little different value in different book, but this is I am talking from genome, right? Okay. So now third factor is also important. Third factor is autonomic nervous system mediated control. We all know that the coronary arteries, they are richly supplied by the sympathetic system and little bit parasympathetic system also. So how this sympathetic system and parasympathetic system is going to control the coronary circulation, right? So we will be discussing this into two parts, that is the sympathetic stimulation, what is the effect on coronary blood flow, and the parasympathetic stimulation, what is the effect of on coronary blood flow, right? So sympathetic system stimulation means the neurotransmitter is all of you know, the epinephrine and norepinephrine is going to be secreted. But you know this this coronary vasculature that we have discussed earlier here, this epicardial coronary arteries, they are predominantly the receptor for this sympathetic system. Predominant receptor is alpha receptor, alpha 1. So we all know that if you stimulate the sympathetic system, this alpha 1 receptor of the epicardial coronary artery, they are going to be stimulated, so it will cause vasoconstriction, right? Vasoconstriction. And this intramuscular artery, they are dominantly beta receptor. They mainly acquire this beta receptor, the beta 2. So we all know that if you stimulate this beta 2, there will be vasodilatation. So there is two opposite effect is occurring because of the sympathetic system stimulation. Epinephrine or norepinephrine, directly it is causing constriction of the epicardial vessels and dilatation of the intramuscular vessels, right? Okay, so if I write here that epinephrine or norepinephrine, the direct effect of this is that vasoconstriction of the epicardial vessel as well as vasodilatation of the intramuscular vessel. But what is the net? Which one will dominate? Obviously, the epicardial vessel, they are the main supply. If you constrict them, the vasoconstriction effect will dominate. That's why this vasoconstriction effect will dominate. That means sympathetic system direct effect is vasoconstriction of the epicardial vessel, means it will try to reduce the coronary blood flow. So I am writing here that this direct effect is reduction of coronary flow. But this sympathetic system has additional effect. What is the additional effect? Beta 1 receptor will be stimulated on the myocardium cells, and that will causes increased force of contraction, or it will causes increased contractility of the heart. So just now we have discussed that whenever there is increased contractility of the heart, more of the adenosine triphosphate will be used, and that will produce increased amount of adenosine. Increased amount of adenosine means what will happen? There will be vasodilatation of the all coronary artery. If there is vasodilatation, what will happen? Obviously there will be increase in coronary flow. So what is the net result? Which one is the main factor for coronary coronary regulation of blood flow? Do you think this direct effect will dominate, or do you think this metabolite effect will dominate? I told you the main factor for coronary blood flow regulation is metabolite. That's why although the direct effect is trying to decrease the blood flow to the muscles of the heart, indirect effect, that is increased contractility of the heart, will dominate, and that's why predominant effect of sympathetic stimulation is increase coronary blood flow. Increase coronary blood flow. That's why whenever you are doing exercise, I told you already that coronary blood flow increases 3 to 4 times than that of the normal, and that is mainly this done by this increased contractility, increased metabolites, increased vasodilation, increased blood flow. Right? Very important, right? Now on the other hand, parasympathetic system, the similar kind of effect will be seen. Parasympathetic means acetylcholine. The direct effect is it will try to causes vasodilation, so it will try to causes increased blood flow. But parasympathetic, the indirect effect is that it will causes a decrease contractility of the heart. Decreased contractility means the net effect will be that decrease in blood flow, right? So parasympathetic, although it is trying to increase blood flow by causing vasodilation, but indirectly it is reducing the contractility of the heart. So the net effect is that decrease in coronary blood flow. Decrease in coronary blood flow, right? So this information you have to remember about coronary circulation, right? Now after that we have to discuss the oxygen consumption of these muscles of the heart. Okay, so far we have discussed the blood flow. Okay, now we have to discuss the oxygen, okay, requirement of the heart muscles. Okay, so oxygen consumption at the level of muscles of the heart. What is the normal value? It was previously asked in NEET exam, that is 9.7 ml, right, per 100 gram of muscle tissue per minute. This is the oxygen consumption of beating heart. Okay, so this is the oxygen consumption of beating heart, so when the heart is working, right? But if you think of the resting heart means if you stop the heart means cardiac arrest is there, but still the heart muscle is consuming some oxygen, and that is equal to 2 ml per 100 gram of tissue per minute. This is known as the basal oxygen consumption, basal oxygen requirement. Basal oxygen requirement means even for the survival of the tissues, even for the survival of the muscle cells, you require certain amount of oxygen, and that amount of oxygen, even the heart is stopped also, but the muscles is surviving, okay, muscles are live, the oxygen requirement is 2 ml per 100 gram of tissue per minute. But when the heart is pumping, when the heart is beating, this oxygen requirement is 9.7 ml per 100 gram of tissue per minute, right? Now, what are the determinant of this oxygen consumption, that how much oxygen will be consumed by muscles of the heart? What is the determinant? The blood flow is proportionate to the ATP used, metabolites. Similarly here, the oxygen consumption is also proportionate to the ATP used. But I have to remember certain factor which are going to change the oxygen requirement. So oxygen consumption depends on certain factor. Number one, more the myocardial muscle tension. Myocardial muscle tension, right? So more the tension at the level of myocardium muscles, myocardium cells, what will happen? More oxygen it is going to require, right? Muscle tension means it is the tension at the level of wall, the force which is trying to tear up the muscles of the wall, that is known as the muscle tension. Now the myocardial muscle tension depends on two things. We have discussed this thing already. One is after load and one is preload, right? So load means that is the tension. We have discussed that during afterload the myocardial wall tension will increase, that is the systolic tension. During preload, the diastolic tension is also increased. So myocardial muscle tension in turns depends on afterload and preload. So afterload increase means there will be increase in oxygen consumption of the muscle. Preload increase means also there will be increase oxygen consumption of the muscles. But increase in afterload, for obvious reason, okay, will increase or consume more oxygen than preload, right? Because preload is due to the diastolic tension and afterload is the systolic tension. So obviously, if you increase afterload and preload same amount, 1%, then afterload increment will consume more oxygen than preload increment, right? Okay. Then second factor is increase in contractility of heart. Okay, increase of contractility of heart will also increases the oxygen consumption by using more ATP. And number 3, increasing the heart rate. Increasing the heart rate, okay, will also increases the oxygen consumption of the heart. Okay, so these are the 3 factors which will increases the oxygen consumption of the heart, right? Now, how this oxygen is utilized? This oxygen which is consumed by the muscles of the heart, this is utilized for which purpose? During the diastole or during the systole, right? So I told you that total oxygen which is consumed by the muscles of the heart, or the total ATP which is used by the muscles of the heart, 25% of the oxygen or the ATP, I told you the oxygen consumption is proportional to the ATP used, 25% is used for, okay, is used for the basal metabolic activity of the heart. This is used for basal metabolic activity of the heart, okay, and 75% is used of 75% of oxygen is used during contraction phase of the heart, during contraction. Now contraction means which contraction? Contraction means systole. Systole means which phase of systole you are talking about. Remember, the maximum, that is 50% of oxygen requirement is utilized during the phase of isovolumic contraction, and remaining 25% oxygen is utilized during the phase of ejection. Getting my point? So 25% of oxygen is used during the basal condition, okay, metabolic activity, basal metabolic activity, and 75% of the oxygen is used during the contraction phase or during the systolic phase. Within this 50% maximum oxygen is used during the isovolumic contraction, and only 25% is during the ejection phase of cardiac cycle. Now, if I ask you that during this isovolumic contraction, oxygen utilization is huge. Why the oxygen utilization is huge? Now, to understand this, if I ask you, tell me how much external work is done by cardiac muscle during isovolumic contraction. What I am talking about? This is, I am talking about external work done by ventricular muscle. You know the formula of external work? Work done is equal to force into displacement. Okay. For a chamber which is ejecting some volume, the formula is P multiplied by V, or V multiplied by P. So volume that is ejected and the pressure against which this volume is ejected. Means if you think of a ventricle, the how much volume it is ejected, that is the stroke volume in one stroke, and that stroke volume is ejected against which pressure? That is the aortic pressure. That had to overcome the aortic pressure. So this V means volume of blood that is ejected by ventricle, and P means this is the pressure against which the ventricle is ejecting. That is the formula for work done by the ventricle, right? So during isovolumic contraction, if I calculate work done by the ventricle, it will be V multiplied by P, but we all know that no volume is ejected during isovolumic contraction. It is an isophase. So the work done will be equal to 0. So although the work done of the ventricle is equal to 0 till the ventricular muscle is utilizing maximum amount of oxygen. Why so? Because this is the phase during which ventricular muscle tension rises to a very high level, and rate of rise of tension is maximum at this phase. What I'm talking about, that during this phase, during isovolemic contraction phase, ventricular pressure will rise from near equal to 4 millimeter of mercury to up to 80 millimeter of mercury, because whenever you cross the 80 millimeter of mercury, then and then only the semilunar valve will open up. That's why the rate of rise of ventricular pressure, think of the Wigner's diagram, the ventricular pressure is suddenly rising from 4 millimeter of mercury to 80 millimeter of mercury within 0.05 second. That is the duration of the isovolemic contraction. That's why the rate of rise of muscle tension is maximum during this phase, and that's why it is consuming maximum amount of oxygen, because I told you the main factor which is responsible for myocardial oxygen consumption is rise of muscle tension, increase in muscle tension. That's why please remember that during isovolemic contraction, external work done is equal to 0, but still it is consuming huge amount of oxygen. Now if I ask you that during ejection phase, if you calculate work done by the ventricle, obviously it will be positive. Now you calculate work done of left ventricle during the ejection phase. So I am thinking of left ventricle. So this is my left ventricle. Left ventricle is ejecting blood. Okay, how much blood is ejecting? That is the stroke volume it is ejecting, and it is ejecting blood against which? That is against the aortic pressure. So what is the aortic pressure? The mean aortic pressure I have to take. So stroke volume multiplied by pressure. So stroke volume, okay, I should write down mean aortic pressure. So stroke volume is 70 ml to 90 ml. So I am taking 70 ml suppose, and mean aortic pressure is 93 millimeter of mercury. So this will be the work done by the left ventricle. Now if you calculate the work done by the right ventricle, that is equal to again the same thing, stroke volume multiplied by mean aortic, in place of mean aortic pressure, mean pulmonary pressure, right? So stroke volume is same for both the ventricle. In steady state condition, stroke volume is same, but mean pulmonary artery pressure is 15 millimeter of mercury. So I can understand that the work done by the left ventricle is very higher than that of the work done by the right ventricle, and that is not due to the stroke volume, because stroke volume is same in both the condition. That is only due to the difference in this mean aortic pressure or mean pulmonary artery pressure. Mean aortic pressure or mean pulmonary artery pressure is also known as afterload for ventricle. So getting my point? So the work done by the left ventricle is very greater than by work done by right ventricle, and this is due to increase afterload in case of left ventricle. Getting my point? This is the question that has been asked multiple times. Okay, that work done by the left ventricle is more than that of the right ventricle. Why? That is due to more afterload in the left ventricle. Okay, more afterload means more wall tension will be generated. More wall tension means more oxygen consumption will be done. Okay, so now I can understand that left ventricular muscle will consume more oxygen. Okay, because work done is more by the left ventricle, right? But even if the work done is 0, till the muscle can also consume huge amount of oxygen. That means more work done is equal to more oxygen consumption. That is true, but that does not mean no work done means no oxygen consumption, because in case of isovolemic contraction, even if the ventricle is doing no work, but still it is consuming huge amount of oxygen. That means oxygen consumption, okay, oxygen consumption and work done by the ventricle, they are not linearly related. The relationship is not constant. This has also been asked in INI set type of examination, right? So all these things you have to remember about your coronary circulation. Getting my point? Right, great. So now we will be discussing few points about the cerebral circulation. Okay, so cerebral circulation. First, what is written here is Monroe, Kelly, Dr. Innes, right? So two scientists, Monroe and Kelly, they try to apply the physics principle at the level of brain. Okay, so you know that this cranium bone, they are making a solid structure surrounding the brain as well as the fluid which is present inside the brain. Monroe and Kelly for the first time told that total volume of brain, so the brain volume plus CSF volume which is present in the brain, CSF volume plus the blood volume which is present in the brain always remain constant, always remain constant. That means the sum of the volume of brain plus CSF plus blood which is present in the brain, they remain constant inside a very tough structure, that is a bony cranium, right? If there is increase in volume of any of this, okay, there will be compression of the other compartment. Means suppose there is a tumor which is rising this brain volume, so what will happen? This blood supply, the small vasculature which are present in the brain, they will be compromised. Okay, that maybe leads to herniation also. Okay, if the CSF pressure is high, also you know that that can also cause compression of this blood volume, blood flow to the brain. So that applied thing we have also discussed in the the blood pressure regulation chapter. You have seen that whenever CSF pressure is high, the Cushing reflex originates. So that is a part of this Monroe-Kelly doctrine principle, right? Now the normal amount of blood flow to the brain, okay, so blood flow to the brain is equal to 750 ml per minute. Okay, we have seen for coronary it is 250 and here it is 750. So if you express this in terms of cardiac output, that is 15% of your total cardiac output is for circulation to the level of brain, right? Okay, then if you express this in terms of 100 gram of brain, then it is 54 ml per 100 gram of brain tissue per minute, right? You know that most of the blood which is going at the level of brain, that is utilized by the gray matter. So the blood flow to the gray matter of the brain is much more, that is 69 ml per 100 gram of tissue per minute, whereas in case of white matter the blood flow is only 28 ml per 100 gram of tissue per minute. These two additional information is given in genome, so I thought it may be helpful for your purpose, so try to remember that. Now apart from this blood flow, we also have to remember another data, that is the oxygen consumption. So oxygen consumption of brain tissue, the value is 3.3 ml per 100 gram of tissue per minute. Could you recall the beating heart? That is 9.7. So that is very huge. So heart muscle, they uses very high amount of oxygen than that of the brain muscle. So here it is only 3.3 ml per 100 gram of tissue per minute. Okay. Now again the same thing we have to discuss here, that how the blood flow to the brain is regulated. Okay, so regulation of cerebral circulation or blood flow to the brain. Number 1, okay, again the same thing, metabolites. The main control of the cerebral blood flow is done by metabolites, but in case of brain, the main metabolites that you have to remember is carbon dioxide. Increased carbon dioxide causes more blood flow to the level of brain, and this relationship is a linear relationship. Remember this, linear relationship. What do you mean by that? Within a range of 20 to 80 millimeter mercury of carbon dioxide, 20 to 80 millimeter of partial pressure of carbon dioxide, if the carbon dioxide partial pressure is double, then the blood flow will also double. Suppose the partial pressure of carbon dioxide in the brain tissue, in the brain artery was 20 and now it becomes 40, so it is double. The blood flow will also increase double. The blood flow will also increase twice than that of the normal. That is the meaning of linear relationship within this range, that if the carbon dioxide partial pressure is changing from 20 to 80 millimeter of mercury. This has also been asked in MCQ already, right? So this is metabolite theory. Other metabolites are also there, like for H plus ion, okay, potassium ion are also there for this, but main I must have to remember is carbon dioxide. Then second thing is that sympathetic and parasympathetic system has very minimum role. Okay, sympathetic and parasympathetic has very minimum role. What is the minimum role? I will tell you, but before that, number 3 is again the similar kind of thing, that is nothing but auto regulation. We have discussed earlier that what is the meaning of auto regulation, that brain can maintain its own blood flow, okay, constant within a particular range. So what is that range, auto regulatory range in case of brain? That is 65 to 140 millimeter of mercury. Okay, for cardiac muscle we have seen up to 200 millimeter of mercury, but here it is a little less. Okay, so if I plot the curve like this, auto regulation of brain, so it will be from 65 to 140 millimeter of mercury. Now if you stimulate this sympathetic system is stimulated, then there will be right shift of auto-regulatory curve, right shift of auto-regulatory curve. What do you mean by that? Means this curve will be shifted in this direction, means the auto-regulatory power of the brain will be increased, the constant blood flow will be maintained even at a higher blood pressure also. Auto-regulatory power is rising. That is the role of sympathetic stimulation on cerebral blood flow. Otherwise, the role is very minimum. Right now I also told you, so this is all about your regulation of the blood flow at the level of brain. Now apart from this, you have to remember few other points for your MCQ purpose. What is that? The brain is very sensitive to hypoxia, means whenever there is deficit of oxygen, the brain will be damaged, the brain tissue will be damaged. But you have to remember the most sensitive area, okay, to hypoxia, most sensitive brain area in response to hypoxia, and this has been asked multiple times. This is nothing but hippocampus CA1 region of hippocampus, right? CA1 region of hippocampus. Second, the Purkinje cell of cerebellum, right? Not only that, the basal ganglia is also very sensitive, mainly the stratum region of the basal ganglia, and that's why it is written in Genong that the person who is suffering from chronic hypoxia, this basal ganglia stratum area may be damaged, and Parkinsonism like feature may arises in chronic hypoxia condition also, right? Not only most sensitive, the least sensitive, okay, or the most resistance. So the least sensitive area to hypoxia is your brain and spinal cord, right? That is the least sensitive area, right? And it is said that if the blood flow to the brain is occluded for more than 5 minutes, irreversible damage is going to happen, right? So that is the main thing about coronary circulation you have to remember. Now we will be looking at a table where all this blood flow, oxygen consumption, the summary of everything is given, and this is directly taken from Genome. Look at what we have already discussed. We have already discussed this brain, okay? The blood flow is this, right? We have also discussed this, the blood flow per 100 gram of tissue. We have also discussed this. The percentage of cardiac output, that is around 15%, that we have also discussed, okay? So, and in case of this heart muscle, we have also discussed that 250 ml is the total blood flow, 84 is the per 100 gram, and 4.7 or 5% of total cardiac output, that we have discussed. Now apart from this, what else I am going to remember? I have to remember the maximum of all this thing. So if I ask you the maximum blood flow is for which organ? Maximum blood flow in ml per minute. You can find out here, this is liver. Now this column is similar to here, this percentage of cardiac output. Liver is taking maximum amount of blood, okay, in 1 minute, that is 1500. So if you calculate in terms of percentage of cardiac output here, percentage of cardiac output, that will also be maximum. So that way percentage of cardiac output which is delivered to the level of liver is 27.8% or 28% of approximate cardiac output. Then if I ask you that oxygen consumption in terms of per 100 gram of tissue, right, and you can find out here the kidney is maximum, right? So this column, okay, this is very important, that kidney is consuming maximum amount of oxygen when you calculate the oxygen consumption in terms of per gram of tissue, right? Okay, then artery venous oxygen difference, here the unit is given ml per liter, but the unit that I told you already, ml per 100 ml. So that's why if you look at here, the arteriovenous oxygen difference is maximum at the level of myocardium or heart muscles, and that is around on an average 10. I told you 11 to 13, here it is given 11.4, right? So that is the maximum amount of arteriovenous oxygen difference. If you look at the whole body, okay, means the other tissue of the body, I told you that is 4.6, here it is given that I told you around 5. So normal arteriovenous oxygen difference is 5, okay, but heart muscles has the maximum arteriovenous oxygen difference, that is equal to 10, okay. Now if you look at the oxygen consumption, total amount of oxygen consumption in terms of ml per minute, total amount of oxygen consumption in terms of ml per minute, where you are finding out, okay, you are finding out again the same thing, that is the liver is consuming maximum, and this column is similar to here, oxygen consumption percentage of the total oxygen consumed by the body, similarly. So this is maximum in case of liver. But if I ask you that oxygen consumption maximum for 100 gram of tissue, then you are finding out here which one, that is the heart muscle, 9.7. I told you that is the oxygen consumption of a beating heart, 9.7 ml per 100 gram of tissue per minute, and that is maximum. So this is all you have to remember about this table, okay. The other part like this resistance and all, they are not very important, but you may remember additionally. But in every column try to find out which one is the maximum, and this total, this column is similar to this column, and this column is similar to this column. So this is the way to remember this table. So this is all about your regional circulation.